Let's move on. Let's talk about someone presents in, and we're trying to stage them, right? So Brian, when they come in, tell me about conventional imaging versus, say, PSMA scan, bone scan, CAT scan versus our. It seems like everyone's moved toward advanced imaging, or at least trying to. Where does that fit into your kind of practice?
Yeah, so I've transitioned, I think, into doing more of the PSMA PET scans. I think part of it is I'm always worried about cost or trying to be cost conscious, and I think in the beginning, I mean, we're a little bit into a couple years into it now, where at first there was a few sites in our area, so then we were worried, were they going to be able to drive to get it or not, so then maybe you would get conventional, but pretty much all the new patients I see, I'm getting a PSMA PET, unless maybe say their PSA is higher, say it's 100 or 200, you're thinking, well, do we need it?
Yeah.
If I don't think it's necessarily going to alter the treatment, I might get conventional imaging. But most times I'm leaning toward the PET, the PSMA PET, from the start. I mean, obviously in the people that meet the criteria. The one thing I've thought about a little bit, though, is a separate thing is, I guess, surgery patients. So I used to do that. I'm not doing the prostatectomies, but it's somewhat unsettling if you think you're trying to send someone for surgery, and then if you're going to find maybe a microscopic met, is it going to exclude them from surgery? So I think about that a little bit, but I figure, so that's a little bit of a struggle I have.
That's a great point. I mean, we're seeing a lot more things now on PSMA PETs, normal-sized lymph nodes that we ordinarily wouldn't have seen. Rob, where do you see false positives? I mean, where do you see those, and how do you deal with those?
So definitely some of the small little rib lesions you worry about being false positive, and following that up with additional, more conventional imaging to evaluate those. But lung nodules, I mean, I've had several that were primary lung cancers that were not a metastatic prostate cancer that have shown up in the lung. So the PSMA PET imaging is, I don't think it's very, I don't know the exact numbers, but I don't think it's very high, but it does happen in the lung, is for sure. Those are the two main areas I focus on, and then certainly some other physiologic lymph nodes and things like that with other disease states. Some of the ganglion, along the, in the retroperitoneum, those are other things that can, to not as advanced readers might have some false positives.
Yeah, it's a great point. Advanced readers, how important is it? You're reading. You brought up that it was started out as in a couple of places, and then it became more ubiquitous. Do you see a variation, Brooke, in people who read PET scans and the readings that you get?
I think that's always a concern, especially, obviously it takes a lot of trust in your radiologist, and I think it gets easier as we go, but we have a lot of patients that gets imaging at locations that maybe you don't have access to direct imaging. All you get's the report, and that's problematic. I think ideally you are in a setting that it's high volume. Mm-hmm. They're reading it, they're used to the agent that's being used. There's not multiple back and forth between agents. Not everybody has that, but that's the ideal.
I think you brought up a great point. It's so important to look at your scans, because we've found, and I'm sure everybody you've found, ones that are read out negative and, hey, look at this and that, and it's showing up. Is there any role for conventional imaging, Steve, anymore, do you think?
I mean, I'll be honest, I've transitioned mostly to PSMA PET, but as we were kind of talking about, any situation in which you're looking at a scan and it either is overread, underread, something doesn't quite make sense, then I'll go back to the conventional imaging just to see if there's any correlation or complete, no correlation whatsoever between the scans.
I remember we were in a tumor board, I think, and you brought up, when you have atypical variants, right? When you have a sarcomatous differentiation or you have a neuroendocrine differentiation, what are you doing in that situation? Are you still ordering PSMA PET, or are you ordering a different type of PET scan?
If it depends what the predominance of the tumor is, but if it's a neuroendocrine or something, I would definitely have low threshold for getting an FDG PET to evaluate those things. conventional imaging also has a role. You obviously want to be cost conscious, but sometimes you need multiple modalities to look at all these things to make sure you've got all your spots covered.
Yeah. So if we have someone that we're treating, Brian, with castrate-sensitive prostate cancer, what are the keys that you're looking for that are going to trigger you? Hey, this person's at risk to develop castration-resistant disease. You have any thoughts about, is it going to be how aggressive the tumor is, their PSA drop, use like a PSA 90, having the PSA go way down after treatment?
Yeah, that's a good question. So I guess, are you saying when you're first starting, what are the first markers?
Yeah, do you have
First starting?
and some indications that, hey, this patient is going to get into trouble in the next 3 to 6 months. We may have to kind of escalate their therapy. Is there any triggers that you look for when you're following those patients?
Yeah, some of it, for me, I try to look at the whole picture, like even their ECOG status, actually, like when they're coming in, what, when they're first showing up. I mean, if they're showing up metastatic, castrate-sensitive, kind of what was their double time leading up to that. So I'd go back at some of their previous PSAs or the volume, the volume of disease going into it. And then it's funny, recently I had somebody go down, just thinking of this, where I thought they were kind of a newer start to therapy, where I didn't think they had seen much therapy. Their PSA was kind of 50 to 80 range. Started them on hormones, the testosterone dropped, but the PSA went up.
Yeah.
So so that was somewhat surprising. Now the patient had refused the doublet therapy.
Okay.
So it was a little bit unusual. So for sure, you're looking at the first response. Does it drop pretty quickly? The PSA and then just kind of how are they tolerating it? Because I've also had a few people that when they've gone on early therapy, where they just, if they're older, they just kind of functional status drop pretty quickly after going on therapy.
Yeah.
So that seems worrisome, even though it may not even be from the disease. So I think it's a challenging thing for me.
I think those are great points. Steve, are you looking at people who have BRCA mutations any differently, or ATM mutations? Are you going to say, hey, that kind of triggers me to, this guy might be in trouble sooner?
Well, I think we kind of know that when you have those mutations, I mean, a lot of data shows that they do worse. And I'm a big kitchen sink kind of person. If I look at somebody who has obviously, bad disease, whether it's initial bad Gleason score, failure to respond to initial therapy, I'm going to be pretty aggressive. Doublet, triplet therapy will be talked about, in one of the first visits for sure. Yeah. And the rationale behind it, given the genetic mutations.